welcome everybody to the first Advanced Rhode Island CTR Clinical and Translational Seminar Series for this academic year. This is a monthly seminar which features distinguished clinical and translational scientists in our community, and also provides an opportunity for our junior faculty awardees to present their work. This month, I should say, we're really pleased to have Ted Huey here to join us. Dr. Huey is director of the Memory and Aging Program at Butler Hospital, professor of psychiatry and human behavior, and associate director of the Brown Center for Alzheimer's disease research at the medical school. Throughout his career, he has focused on neurodegenerative diseases and uses advanced imaging technology to study these conditions, including genetics as well as physical and psychiatric manifestations. So we're really pleased today to have the opportunity to learn from him about neuropsychiatric symptoms in dementia. So I'm going to hand this over to you, Ted.
Okay, and thanks very much for the invitation to speak. I know that this is a great program, and I'm looking forward to hearing the other talks in it, and I really appreciate all the work you do for the scientific community here. So, Sharon, when we talked about this, wanted me to give a little bit of a sense of background, and then also kind of why I'm interested in what I'm interested in, and I hope that'll come across. As we could talk about the research, but I'm a clinician and clinical researcher, and really I would argue basically all of the research questions I have and I'm interested in come out of the clinic. So I'll be with a patient and and say, that's really interesting, or that's an interesting question or dilemma, and then I see being a clinical researcher is just having the luxury and the privilege to take that the next step of saying, how could we investigate this and how can we get some data on this question? But really the questions come from the patients, which is one of the reasons I've always had clinic, and I still do, and I've never stopped, because I think that really it's a very important part of the research. I'm by training a geriatric and neuropsychiatrist, and so as Sharon said, really one of my main interests is behavioral symptoms and neuropsychiatric symptoms and presentations of neurodegenerative illnesses. So again, as I said, I'm a clinician, so I start a lot of things with cases. And I'm also going to ask, people don't have to speak up, but I will be asking some points where people can talk about stuff, and I'd be, so if you can turn your mic on and just answer if I ask a question. So this is a case, and this is a typical kind of case I see pretty frequently. A woman comes to talk to you about her middle-aged brother. She's concerned because he's having some changes in the last 6 months, or possible changes. She reports it's relatively subtle, but he seems a little more kind of withdrawn than before, maybe reaching out to her a little less. And then 2 episodes of buying more items than he needed on Amazon. They were kind of things he sort of needed, but he bought a bunch of each of them and did it twice. When you talk to him, he says, oh, she's just worrying too much. I just made some mistakes on my orders. I don't really feel any different, any changes. He's denying any problems with his mood or an anxiety. And on a screening exam, cognitive exam, he scores normally. So, this is someone I might see in my clinic, and maybe I'll take, maybe I'll ask you for the next one here, next part here. So, my impression of, it would be that this would be something, just keep an eye on it, see what's going on. It probably wouldn't require any further testing or really much thinking about it. But let me give you another piece of information, which is the siblings' father had a tau mutation, which is associated with behavioral variant frontotemporal dementia with very high prevalence. And their father was diagnosed at 50 years old. Neither of them have had genetic testing, so we don't know either of their genetic status. Frontotemporal dementia, which is a disorder I'm going to be talking about a fair amount in this talk, is a neurodegenerative disorder which affects people usually in middle age and presents with quite prominent changes in behavior and neuropsychiatric changes. So I guess the question I have for you and to think about is, does that change the way you look at the first bullet item? In other words, would you do things differently? Would you, would you pursue it more? How would you kind of start to tease apart? Could this be early changes for frontotemporal dementia, or is this kind of what we see in someone who's just normally aging? And Sharon was saying what kind of motivated you to do what you do. I would argue this case in this question is a big part of it. I see a lot of patients where this is kind of the question: is something is changing? Is it, what is it due to? So I would argue, and this is kind of the problem that this case reflects, is we really don't have a great understanding of neuropsychiatric symptoms in dementia. So this is kind of three-legged stool of potential symptoms of neurodegenerative diseases, and you've got motor symptoms, cognitive symptoms, and then neuropsychiatric symptoms, which I think can be interpreted kind of more broadly as any non-motor, non-cognitive symptom. So it can encompass mood changes, anxiety changes, sleep changes, appetite changes, motivation. And the neuropsychiatric symptoms are very, very common. So really, they're pretty much ubiquitous, not just in disorders like frontotemporal dementia, but in Alzheimer's disease as well. The vast majority will have at least some of those changes. They're very burdensome. So if you talk to families, they actually often find the neuropsychiatric symptoms more burdensome than the cognitive symptoms, especially things like agitation and psychosis. And they also greatly increase the chance someone is going to get put into a nursing home or out-of-home placement, and the cost of caring for someone. And I would argue they're much less understood than the other two legs of this stool. So, I do a lot of consensus conferences and diagnostic conferences. And, when we talk about a patient and present them, the neurologist will say, well, this person is Parkinsonian. And, immediately we have a kind of an anatomy we associate with that. We have a cluster of symptoms we associate with that. And then the neuropsychologist will say, and they have a learning deficit, suggestive of hippocampal dysfunction. And again, we have a kind of anatomy, we have a system for that. And then, the psychiatrist will say, well, and they're depressed, and we don't have a kind of a comparable system for that. How do we think about that? What's the anatomy of that? And I think that it's really kind of held us back in relation to these other symptom clusters. This is a study we did a couple of years ago. And it's looking at, these are neuropathologically diagnosed cases. So these are all autopsy cases of patients with different neurodegenerative disorders here along the horizontal axis. And the disorders are Alzheimer's disease, Lewy body disease, cerebral amyloid angiopathy, vascular dementia, frontotemporal dementia, and hippocampal sclerosis. And just looking so we're seeing them, these are the diagnoses at autopsy. If you go back through their disease course, and this is using NAC data, how many of them had different neuropsychiatric symptoms? And these are the symptoms from the 12 symptoms from the neuropsychiatric inventory. And a couple things to kind of take home here. One is that, this supports, I think, what I was saying before, that these symptoms are very common. So if you look at even just like something like apathy, 70-something% will have it at some point in their illness, and that's just one of these 12 symptoms. So the vast majority of people will have some neuropsychiatric symptom. The other thing I think to notice is that it's not that a symptom is diagnostic of a certain illness. So, it's not that you can say, oh, if you have apathy, you have frontotemporal dementia. If you have, hallucinations, you have Lewy body disease. Really, these disorders these symptoms are, it's more the distribution, or I would argue kind of the fingerprint of the symptoms people have that may be characteristic of a particular neurodegenerative syndrome. But obviously that complicates diagnosis. A third thing I think to notice is that, some symptoms are more common for everyone, and some are really not very common. And one thing we're going to talk about a little more is that that our definitions of a lot of these symptoms are really borrowed largely from primary psychiatry, and they really may not fit so well into what the symptoms that patients with neurodegenerative disorders are presenting with. One other thing I just want to note, and again, not to get too into the weeds, I don't know if they're dementologists on the call, but if you look at one thing I think is also interesting about this study is the discrepancy you can see between kind of our clinical syndromes and our neuropathologic syndrome. So if you look at hippocampal sclerosis, which is a relatively uncommon disorder associated with deposition of TDP-43, especially in the hippocampus. When we think of that, and the clinical criteria for hippocampal sclerosis is that it's a relatively indolent course, mild course, focused on memory, not a lot of other symptoms in the oldest old, and not really associated with behavioral or neuropsychiatric symptoms. And those are the patients we diagnose with hippocampal sclerosis. If you turn it around and look at the pathology of hippocampal sclerosis, so you take patients with neuropathologic hippocampal sclerosis and then look at their disease course, you actually find hippocampal sclerosis has prominent behavioral and neuropsychiatric symptoms. So, we're always trying to kind of mesh what's going on in the brain and the neuropathology with the phenotype, but clearly, those don't always match up, and the criteria kind of have to catch up with the pathology. So this is just saying more about the problem. Early neuropsychiatric symptoms are really the presenting symptoms for several different neurodegenerative disorders: behavioral variant, frontotemporal dementia, Huntington's disease, Lewy body disease, TES, which is the clinical syndrome associated with CTE. This new diagnosis late is kind of up in the air. We're not sure, but they really have been difficult to kind of work with, both in integrating it into diagnosis and also using it as outcomes. So this is just kind of proving it to you. So primary progressive aphasia, which is primarily a language disorder, which I see a fair number of these patients as well. And, it has the language symptoms, which makes sense. But then if you go down to the exclusion criteria, number 4 is that they can't have an initial behavioral disturbance. So, so if they have prominent behavioral symptoms early, and of course that rules out the diagnosis of primary progressive aphasia. Now we know from studying these patients, many of them, actually the majority of them, have prominent initial behavioral disturbance. So we're kind of left in this limbo of, do they have PPA? Do they not? Why is that an exclusionary criterion? Another example of this is Huntington's disease. So Huntington's disease is the definition of it is purely motor, defined on motor symptoms, so that you cannot get a diagnosis of Huntington's disease without motor symptoms. I see a fair amount of Huntington's disease patients too, and they very frequently will have early prominent psychiatric symptoms for many years before they develop motor symptoms. And so what do we call those people? Do they have Huntington's disease? Well, they're having symptoms of it, but they don't meet the criteria. Why is this a problem to our kind of lack of understanding or lack of detecting early neuropsychiatric symptoms? Misdiagnosis is a clear problem. And so for frontotemporal dementia, which is a disorder I'm going to use kind of as an example throughout, when you talk to families, it's one of the biggest problems, they say. They go years usually with being told it's depression, it is bipolar, it's obsessive compulsive disorder, before they actually get the correct diagnosis. And they report that as being very difficult. And they put that on the top of their problems, the workup of frontotemporal dementia. The other thing is, as we're developing disease-modifying treatments, and we do have a few that have been approved for Alzheimer's disease, pretty much there's pretty universal agreement that these treatments will be most efficacious early in the course of the illness. And so the misdiagnosis and lack of early identification of these patients then becomes a real problem, because there's no point developing disease-modifying therapies that are targeted to very, very early illness when we're not detecting very, very early illness. And for something like sporadic frontotemporal dementia, the majority of patients go usually several years before diagnosis. Underpowered clinical trials. So this is the thing I skipped on this last slide here. This was a trial done by Biogen, and they were studying a drug for a mutation called C9 open reading frame 72, which is the most common genetic mutation cause of both frontotemporal dementia and ALS. And interestingly, it can present as both or either. So patients can present either with frontotemporal dementia or ALS or combinations thereof, and even within a family that can vary. And when they did their study, like most studies that are done with these kinds of patients, they only did it with ALS. So they said, well, the behavioral neuropsychiatric symptoms are just too tricky and, difficult to wrap our minds around. So they didn't use them in the trial. So right off the bat, you've got a relatively rare population of patients with C9 or F72 who could benefit from an investigational genetic treatment. But we're right off the bat, we're kind of having, or even more than having, our power of the trial just because we don't understand and are not able to measure these symptoms well, which is a real problem, I would argue. Another reason why this is a problem is that it really, if we want to understand these illnesses, and again, especially these neurodegenerative diseases, which present very much behaviorally and neuropsychiatrically, and including the areas of the brain they affect, we really need to understand these symptoms better. And then, as we said before, these symptoms are very problematic, and so a lack of identification and kind of thinking about them can prevent people from receiving needed symptomatic treatments. Now, there are reasons why we know less about this, and there are fewer measures and everything. There are some challenges when you're assessing and thinking about neuropsychiatric symptoms you don't have when you're thinking about motor or cognitive symptoms. One, and I think this is probably the biggest problem, is that psychiatric symptoms or emotional symptoms or behavioral symptoms, whatever you want to call it, not associated with neurodegenerative illness, so from primary psychiatric disorders, are very common. About 25% of people will meet criteria for an axis 1 disorder, like major depressive disorder or generalized anxiety disorder, at some point in their life. And so, that makes it very hard or makes it very pressing to distinguish between the symptoms of a primary psychiatric disorder and of a neurodegenerative disorder. As I've said kind of throughout, I think we don't really understand neuropsychiatric symptoms well enough to be able and that gets in the way of assessing and distinguishing neuropsychiatric symptoms from primary psychiatric disorders. And then I also mentioned this is that we're really borrowing a lot of this from primary psychiatry. And I think, and have some data to show that that's a problem. And then, neuropsychiatric symptoms, rely on subjective report, and, unlike, weakness in an ALS patient, which you can see, or fasciculations, you have to rely on report for many of these symptoms. And the patients may not be reliable reporters, and also the informants. And then another thing, which is, a complication, is that these people are often under enormous stress, which is a risk factor for primary psychiatric illness. So, so either a lot of these from genetic families or from families with genetic illness, which is its own stress. And then if people have symptoms, those are their own stress too. And this really can kind of interfere with a lot of the measures we borrow from primary psychiatry. So like I see patients with ALS, and I see them from the cognitive and psychiatric side. And if you use psychiatric screening measures, psychiatric screening measures are very focused on assessing suicidality, and for understandable reasons. But they'll have a lot of questions like, do you think about death, or do you think about your own death? Well, if you have ALS, that is actually, you should be thinking about your own death, and people will. And so these measures kind of, again, just are not so applicable for our neurodegenerative populations. So how can you distinguish symptoms related to neurodegeneration versus due to kind of non-neurodegenerative factors? And again, I would bring you back to our case where someone is having these very subtle changes. How do you kind of tease that apart? Whether, is this early FTD? Should you be screening them for a trial, or, or changing your prognostic outlook? Or is it something you just kind of say, well, things happen over the course of the year. So there are some things, just to kind of, before we get into the data, that we can use. One is time of onset. So for reasons we don't really understand, primary psychiatric disorders are generally disorders of early life, so of youth and then early adulthood. If someone develops something late in life, that's rare for primary psychiatric disorders. So I see a lot of patients where they'll develop depression, other symptoms at the age of 75 for the first time, and that is often a piece of evidence that it is related to a brain change that is going on. Rarity of symptoms. So, I've been talking about depression and, feeling down or withdrawn or things, but there are symptoms like visual hallucinations, which are actually really quite rare, even in primary psychiatric disorders. And so if someone develops those, it can be a tip-off that this is related to some underlying neurodegenerative process. Obviously, the course of the symptoms You know, a lot of primary psychiatric disorders are waxing and waning. So depression, bipolar disorder are kind of, you know, have a time course to them. So I'll sometimes see patients and they'll say, well, you know, we're having trouble distinguishing, could this be FTD or is it bipolar disorder? You know, he's been manic for 2 years. And, you know, when I hear that, I think, you know, mania is not a stable mood state. And so probably that reflects some change that's going on in the brain. And then associated non-psychiatric symptoms. So the primary one for that being cognition. So that if someone is developing, 75-year-old develops depressive symptoms, but then also on testing has some memory symptoms, that can be a tip off. Although, as I think I've shown you, for many of these disorders, psychiatric symptoms can be the first. And so we don't actually have that cognitive association. And then, and this is something I'm very interested in, is the clustering of psychiatric symptoms. So if you look at, you know, let's take something like depression. It's one of those things where kind of, oh, everyone, you know, knows what depression is. But when you really look at it, you know, what is depression? So if you look at DSM, which is the psychiatric manual, you know, it's a cluster of many symptoms. I think it's 9 or 7, I'm forgetting exactly how many, but including, you know, sleep disturbances, appetite disturbances, feeling dysphoric and down, suicidality, energy changes. What are we talking about when someone, again, develops depressive symptoms associated with Alzheimer's disease at the age of 75? Does it look the same as an 18-year-old or not? And I think mostly not, but we'll show you some data on that. So let me this is something I'll open up to a question. What would you do if you wanted to thinking of that case we had initially, you know, and again, if people weigh in, if you don't, that's fine too. I'll answer it because I already did answer this in designing the studies. What would you want to collect to help you answer that question that I brought up in the case of what are is this an early symptom of FTD? Is it not?
Can I? Yeah, I'll answer.
For sure.
I would do a genetic test.
Okay.
First, for that particular case because of the family history.
Yep. And that could definitely tip you, because if the person doesn't have the gene, you know, case closed in a way, because, you know, again, it's a pretty, you know, it's pretty black and white with the many of these disorders. I would argue if they do have the gene, it's a little more complicated, because they still could be having, you know, neuropsychiatric changes that are not related to their illness, but it definitely, your pretest probability in Bayesian terms goes way up. Anyone else? So that's a great answer. So, you know, thinking in terms of a study, one of the things with some of these disorders we can leverage is that they are genetic. And so the advantage of that is that it allows us to identify we're very, very early or pre-symptomatic cases. I told you that FTD generally gets misdiagnosed, and that's definitely true for sporadic illness and for unidentified genetic illness. But often we'll identify a family, and this is the case you saw, where they have genetic illness, and then we can really diagnose them much, much earlier. So what we did is we really wanted to leverage these genetic forms to look at prodromal cases. So really look at the earliest cases, like that one I showed you. And the question that Sharon actually said, which is, when we look at these cases, knowing that we're you know, ignorant about what the symptoms will be and what they'll look like, how do we distinguish from mutation carriers from non-carriers? So these are people, they have very similar stressors, they have very similar family backgrounds, they're within families, by definition. What symptoms can we feel confident saying, yeah, that's associated with mutation, that's not? And then how do we compare that to other diagnoses, like people who are healthy, their healthy siblings, Alzheimer's disease, psychiatric illness, and then also looking at defining individual symptoms that might help us. And we wanted in this project to look very broadly: cognitive, neuropsychiatric, behavioral. We wanted to not go into it feeling like we knew what we were looking for, but instead to say, what should we be looking for? We got data from a bunch of sources. We basically, the first one is a study, was my first R01, looking at one very large tau mutation family. The second one is a national consortium looking at frontotemporal dementia. And then NAC, which is another national consortium focused on Alzheimer's disease, but actually has a fair number of frontotemporal dementia patients in there. So basically, between these three studies, we're capturing, as well as you can, really the patients with genetic and sporadic frontotemporal dementia in the family. This is just I did with Stephanie Cosentino, R01, on this very large family with a tau mutation. This is the paper. It was in Brain a couple of years ago. You can look up for details. So I'll move sort of quickly. This is Megan Barker, who really did this and led the analysis, and she actually works with me here at Brown. So what we did is we identified all of this out of thousands of participants in these studies who had what looked like what was this question of prodromal behavioral variant FTD, and we defined that by, and again, I know I don't want to get too into the weeds here, but like a clinician, a CDR score of 0.5. And what that means is a clinician is saying this person has questionable symptoms. So that's someone who's trained to identify these people, someone who's worked with these people. And they're saying, I see something I'm not sure about, but they don't meet criteria for FTD. And this is kind of exactly the people we wanted to see. Out of those many people, we identified 72 from those 3 data sets that met those criteria. And then we compared them to similarly aged mutation negative family members. So those were our controls. Now, this is a mixed group in that some people knew their mutation status, many people didn't. We kind of put them all together in the mix. And then we also compared them to an Alzheimer group. Here you can see kind of, I won't go through all the details, but we started with over 1,300 people, and that kind of boils down to 72 people who meet our criteria of people who are going to be very informative. We split those groups actually into 2 groups. So one was our development group, and these were the 22 people of those 72 who were just really, for want of a better word, perfect for this study, in the sense that they were seen in a research evaluation when they were prodromal or thought to be prodromal, and then they were followed for several years afterwards until they developed FTD. And the nice thing about that is we could see what the symptoms were that persisted. So some symptoms we could say, oh, that one didn't stick around, but this one actually really appeared to be a progressive early symptom of their disease. And then we used those to develop our symptoms we wanted to look at, and then we tested it in the other 50 to see how well does that predict who is a mutation carrier and who isn't, when you're looking just at this very early prodromal side. I'm going to go quickly through these because, again, I think this is kind of inside baseball. So we looked at a bunch of neuropsychiatric and behavioral symptoms. We also did this where we reviewed all the charts, and this was a lot of work, and Megan and Masood Manachahari, who's in my lab, did a lot of this. And we extracted for mentioning of all of these. And the reason we did that is there's a circularity if you use these scales and then just see where they should go on the scales. You don't really identify new symptoms that might be involved. So we really wanted to do that. And so we basically looked for a range of symptoms that were not necessarily on the scales and ranked those as well. And again, this is inside baseball, but this is the cognitive battery and the social cognitive battery. And those we used kind of standard cutoffs. And I think we talked about this. We had a development group where we identified the symptoms, and then we had a validation group that was not, either we didn't have as much follow-up, or they didn't kind of go on to develop BVFTD. Maybe they developed another syndrome, or they were sporadic cases from NAC. I'll skip this. This is just, again, it's in the paper if you want to see who the different groups are, the mutations, et cetera, et cetera. What we did with our analyses is we treated each symptom like a diagnostic test. So we calculated sensitivity and specificity and ROC curves to basically say every single symptom, how well does it function as a diagnostic test to distinguish mutation carriers from non-carriers? And we used a priori kind of rules for diagnostic tests. So we wanted our target area under the curve to be 0.7 or greater, which is a sign of a pretty good test. We prioritize specificity because we wanted to pick things up. We didn't want to have symptoms that were so rare, or we didn't want to kind of put those into our, because we were making new criteria. We were making criteria for prodromal BVFTD. But we also wanted them, we prioritized specificity because we didn't want a lot of a false positive, but we wanted sensitivity so that it wasn't so rare. Sorry, I said that the wrong way. So we've had that. These were our a priori rules. And these are our results. And so the symptoms in red are ones that met all a priori rules. The symptoms in blue, the area under the curve wasn't quite to 0.7, but we actually included them in our criteria because they were close and we thought they were actually useful and important. So a couple things to notice. The first thing is all of the symptoms that identified early FTD are behavioral neuropsychiatric. So the cognitive testing it didn't do it. It did okay. I mean, you can see that, they perform again okay, but certainly not as well as behavioral symptoms. Also, our social norms cognitive tests. So these were tests on social cognition, which is also affected in FTD. Again, didn't make the cut. The ones that really did well, again, neuropsychiatric. And another thing to notice is they don't really fit primary psychiatric disorder. So we have apathy, but these people actually weren't depressed. They weren't dysphoric. Disinhibition, irritability, agitation, which had not really been kind of so associated with FTD before, reduced empathy, sympathy, repetitive behaviors, appetite changes, almost always eating too much. And then this symptom, which was interesting, which is joviality, gregariousness, sort of over approaching. So these were people who, and I know this from my patients, they kind of lack boundaries in approaching. So like I used to practice in New York, and they would go up to baby carriages on the street and really just get in there or even pick up the baby. And this turns out to be quite a specific symptom. So if people start doing this, this is actually very unlikely to be anything else. This is very likely to be FTD. Same thing with reduced empathy, sympathy. It doesn't really happen in people normally. Psychosis was kind of interesting because it was very specific. So meaning if people develop psychosis among these mutation families, that was pretty definitive for FTD. It just was so rare. It just didn't happen that much that it didn't end up being in our criteria. So from these, we made new empiric kind of based on, on these findings criteria for how to diagnose early BD-FTD, so prodromal, and it really did quite well. It worked well in the development group and well on the validation group as well. When you compare it to healthy controls and Alzheimer's disease, it does quite a good job of distinguishing them. So questions about that study? Okay, I'm going to talk about one more study, and then we'll be done. So that was really interesting, and I learned a lot from that, and it really, and again, I really can thank Megan Barker who set all of this up. What I really learned about it, in some ways, I think, is that these questions can be tractable. So like that case I showed you at the beginning. Yes, these are difficult questions, but we really can get data on them, and we can start to treat these symptoms and get numbers to empirically test them. And one kind of theme I've had throughout all my research is, it's not that I think neuropsychiatric symptoms are always going to be better at performing for clinical trial outcomes, et cetera, than cognitive or motor symptoms. It's more just that I think we really want to know. We want to be able to compare. And there may be situations where, there are lots of situations where you want to use cognitive or motor symptoms, but there also may be situations where psychiatric or neuropsychiatric symptoms could be most valuable. Again, as I've made the case, especially when you're looking at very early illness or these neurodegenerative diseases that present with prominent neuropsychiatric symptoms. So there were and still are some barriers. So one thing, we came out of this project and I was like, we really don't have good measures. We really, the measures we have currently really don't, they're very Alzheimer centric. And as I think you can see from the FTD work, the symptoms of FTD or psychiatric symptoms are quite different. And they don't take into account this different structure between primary psychiatric disorders and neurodegenerative disorders. They really pretty much borrow from psychiatric scales and primary psychiatric disorders. They also don't capture these symptoms like the joviality or gregariousness that really we don't see very much in primary psychiatric disorders. And they're very old. They don't take advantage of the data we've accumulated over the years. So I won't make you go through this, but we wanted to collect data to kind of address some of these barriers. And it's not rocket science in some ways. What we did is we did a study where we looked at a bunch of diagnoses now. It's actually heavily weighted to Alzheimer's disease, largely because that's so common. But we wanted to kind of have a data-driven approach to figure out what are the symptoms they're showing and how are they clustering together. So we did, and then to define kind of what's the factor structure. And the idea behind this project was that when we know really kind of what the factor structure is, actually a lot of the other things might get clearer. The neuroanatomy, how we detect them, the measurement might improve to try to kind of bring it up to where we are with cognitive and motor symptoms. So we looked at over 200 people. We had a range both from unimpaired to MCI, almost entirely from Alzheimer's disease, people who met criteria for mild Alzheimer's disease, frontotemporal dementia, Huntington's disease, and other, which includes Lewy body disease, Parkinson's disease, dementia, et cetera. I won't spend a lot of time on that. And what we did is we took the SCID, which is, it's been developed in psychiatry. And when the original use of the SCID is as a diagnostic interview. And so when you do it, and some people here may have done the SCID, I've done a lot of them, it takes you through kind of how the questions you need to do to diagnose these primary DSM psychiatric disorders like major depressive disorder, bipolar disorder, et cetera. And we did it a different way. We gave every question on there. So that's over 1,000 questions. And what we were thinking about is that psychiatry is, has its limitations in relation to neurodegenerative disorders. But one thing it has done well is to really kind of assess all the different kinds of, or most of the kinds of symptoms that can come up in people. And also another advantage of using this measure is it's been collected in lots of people with primary psychiatric illness. And so when we want to compare them and see really what the differences are, we can do that. We selected, many of these items are actually kind of derivative of other items. And so we got 140 items a priori that we wanted to look at. And again, using it as a broad measure of psychiatric symptoms. And this has been done at Brown with Alyssa DeVito and Zach Kunicki, great collaborators, and Megan as well. I'll kind of go quickly through the statistical parts of it because we're coming close to time. We basically ran an exploratory and then confirmatory factor analysis on these, however many it was, 100 and something symptoms. And this is what we get. So we get an 8-factor model. So again, just to reemphasize, when you do a very broad kind of not coming into it just saying what the symptoms are going to be and how they're going to cluster, but instead letting the symptoms kind of talk to you, here's what you get in neurodegenerative disorders. One symptom is cluster is emotional blunting. So these are people, like it sounds, it's closely tied to apathy. And I think it's an interesting debate, kind of what's emotional blunting versus apathy. But this is where families are reporting that they are not as emotionally responsive as before. We found 2 anxiety factors. One is kind of a more all the time generalized anxiety, and one was a more kind of acute panic type of anxiety. Which is actually does overlap significantly with primary psychiatric disorders. We found our most common symptom actually was sleep disturbances. And that was kind of interesting because that split into basically kind of insomnia, sleep disruption, and then actually the most common neuropsychiatric symptom we saw in our Alzheimer's patients was hypersomnolence. And again, this clinically fits for me. These are the patients who they sleep actually fine at night, but then they're sleeping for much of the day as well. And this is, it's the kind of thing where, you don't find out about it unless you probe because it's not like agitation or things like that where it causes real problems, but it's actually very, very common. Aggression came out on its own. Obsessive compulsive disorder, or obsessions or compulsions, so repetitive thoughts or repetitive behaviors clustered together and kind of were their own thing. Actually, a lot of this clustered with, I think I'll have some of the data, with psychosis too, with delusions. That kind of when people had a lot of repetitive thoughts, often they were delusional thoughts. And then we have depression, but this is really, and I can show you the kind of factor, the items leading to it, really more dysphoria of that overall depression schema. This is just showing you kind of some of the factors that contributed to it. So emotional blunting, diminished emotional blunting, interestingly affects insight. So people have less insight. And again, we can debate how much of this is you would call apathy versus that. Generalized anxiety, muscle tension, restlessness, worry, et cetera, et cetera. Sleep disturbances, so trouble maintaining sleep, initiating sleep, early waking, insomnia. Hypersomnolence, excessive sleepiness, fatigue, hypersomnia, obsessive compulsive disorder. So again, a lot of recurrent thoughts, recurrent behaviors, but then also delusions, kind of sorting with that. And then panic. And then aggression, agitation, which had irritability in it, but also a fair amount of aggression, aggressive symptoms. And then depression, which actually is sort of interesting with visual hallucinations, depressed mood, guilt, and suicidality. We're still working on these data and writing the paper up and thinking about it, but we're kind of looking also, we're very interested in what are the associations, what are the correlations. So for example, we're finding, and this fits with actually some of the literature on primary psychiatric disorders, we're finding a pretty fair association of what we would call internalizing. So, combination of depression and anxiety. And when you look at the factor structure of primary psychiatric disorders, those are tightly linked. It's hard to distinguish anxiety from depression when one is looking at larger factors. And we see kind of similar patterns in people with neurodegenerative disorders, sleep disturbance and anxiety, emotional blunting, actually with aggression. So again, 8-factor model appears to have face validity. I think I've talked about most of these findings. One thing just to stress is that apathy is not the same thing as depression. So we really found them, and I think this clinically fits with me, that with my experience, that people can be apathetic without actually being at all dysphoric, and people can be dysphoric without being at all apathetic. That even though we've combined those when we think of young people, and the two kind of hallmarks of depression in young people are lack of motivation and dysphoria. They really appear to be quite distinct syndromes, distinct symptom clusters in people with neurodegenerative disorders. When you break it down by diagnosis, the numbers get small, and we're kind of building this up. And it's kind of, I won't spend too much time on it, but there appear to be some kind of clusterings, and with frontotemporal dementia and Huntington's disease having a fair amount of overlap, with a lot of emotional blunting, repetitive behaviors and thoughts, really being kind of two hallmarks of those two disorders. And that being, these being two disorders which we know are really most directly affecting frontal syndromes, frontal systems in the brain, so the frontal lobes. And if you look at the more posterior disorders, Lewy body disease, Alzheimer's disease, we're seeing more of those internalizing symptoms, generalized anxiety, depressive symptoms, and then also, sleep disturbances, especially with Lewy body disease. So what we're doing with this, one of the main, we're comparing it, we're getting more data on it, we're looking at other measures. One of the big things we're doing, and we're pretty much ready now, we're creating a new measure. So we're basically saying, let's have an empiric data-driven measure based more on these kind of how the data is actually clustering, that will, again, help us to determine more of the biology of the illness. So thanks to everyone, especially patients and their families. I think you can tell that none of this research could happen without them. Thanks to my lab, especially for the data I've been presenting, Megan Barker and Masood Menacheheri, where do I see him? And Claudine Narayan, can't find her right now, and Nicole as well. And then this is the ending slide, and just up next we have Friedman and Maren Mann.
Thank you so
Just on
much.
time.
Bravo. Thank you very, very much. That was really terrific. We welcome questions. I guess I'll start off with a couple of questions. This will sound really naive, but I'm not a geriatrician, but I have observed that when older people who are fine, they're functioning great, they get sick with some acute inflammatory process, and they get whiffy and, and almost acting like they're demented. What do I know? But they're the same. And then they get better and it goes away. Is that possibly a early sign of a neurodegenerative disease, these changes with an acute medical process?
Yeah, that's a great and common issue that comes up. So definitely, so people can get delirious, and obviously that can happen to a 18-year-old. But the threshold for getting delirious goes down as you age, and certainly as you have any other kind of concomitant thing going on, Alzheimer's disease, or so. Like I saw this a lot with COVID, where people would get COVID, they'd get some, and it would just cognitively knock them for a loop. And for a lot of those people, we were probably, it was like a cardiac stress test or something. We were probably uncovering kind of incipient changes that were going on. And, but they usually, it put a kind of an extra stressor on top of them. And so, yeah, definitely. And a lot of times when you take a history from families, they'll say, yeah, dad was, dad has memory problems now, and he was really fine until his surgery or until he had COVID or until, and I think they're being accurate. They're reporting it accurately in the sense that, he's doing okay and then he takes a drop and sort of doesn't bounce back from that. But our kind of biological sense of that is that probably something was there and it probably would have declared itself in a year, 2 years, but the episode of delirium really kind of pushed them over the edge. So you definitely hear that a lot. And yeah, and I think there's real truth to it. There are also kind of neuropsychiatric effects of these illnesses, and you hear a lot of people say, I mean, COVID, again, it's come up a lot, but like when I had COVID, I got really depressed. And and I just felt, all the symptoms really of depression and the cytokines, things that when we're acutely ill, are pro-depressive. They can make one feel depressed. And probably depression, I mean, one thing, this is kind of a different talk, but like these things don't just come out of the blue. Anxiety, depression, things like that have functions. And anxiety as a motivating factor, depression often as a kind of you're wounded, you can rest and withdraw and heal. They just can become problems when they're inappropriately activated. So we definitely see that too, where people say, yeah, I got really depressed when I had COVID. Now I don't feel, once I got better. So a lot of brain body interactions here.
So what about a blood test or some kind of biomarker for early dementias?
So we do have biomarkers for neurodegenerative processes, and they're more and more by the month. So now we have, you can go and get a lab test for Alzheimer changes for amyloid, amyloid basically, and you can get a PET scan as well. The thing that's been, kind of bedeviling the field about that is that there are a fair percentage of people who have those changes but are not having symptoms. And so if you go out to the street and you take a whole bunch of older people off the street and give them either a PET scan or blood tests, a fair significant proportion will be positive, even people with normal cognition. And those are the people probably, again, they get delirious, kind of tips them over. They're at higher risk for developing clinical Alzheimer's disease, but they're not there. And we know that Alzheimer pathology develops 15 years before you get symptoms. It's kind of chugging away. So there's been a lot of debate, some of it even contentious within the dementia field of what, when we say Alzheimer's, what do we mean? So someone who is walking around who will be positive on a biomarker test, but could be working their job, could be doing fine. Is that Alzheimer's disease? And the field has kind of swung that way. If you look at the most recent criteria for Alzheimer's disease, put out by one group especially, they say yes, that's Alzheimer's disease, and it's just asymptomatic. But then when you talk to people, I think most people would say, well, that's not Alzheimer's disease. That person's fine. They're not having any problems. Alzheimer's disease is when you can't remember stuff, and when everybody knows that, but it's in flux, and we're developing biomarkers for other ones too. So we have pretty good biomarkers for Lewy body disease, for alpha-synuclein illness. So it covers both Lewy body disease and Parkinson's disease. We don't yet have them for FTD, but we're really hoping we will. But I think that'll really help. That slide I showed you about the pathology, it's really going to help with that kind of research, where right now we have to wait till someone dies and then we can look back, like that study we did. In the future, I think we're going to much more say, define the phenotypes associated with these neuropathologies better, because we'll have it in living people. And I see a fair number of people, and this is an interesting group of people, where they come in, they have memory problems, progressive, they look like Alzheimer's disease. 15 years ago, we would have said, oh, you got Alzheimer's disease. And then we do the biomarkers and they're negative. And so then we kind of are left with, well, what is it? And we kind of have to, it's led us to kind of learn about the contributions of other non-Alzheimer pathologies I think we didn't appreciate before.
see, do we have other questions? Can we better utilize digital health tools and technology to monitor these symptoms and provide timely, personalized interventions?
Yeah, that's a great area, and there's a bunch of people here. Actually, Louisa Thompson, who is supported through CTR, it works on the digital assessment, and another faculty member here, Alyssa DeVito, works on passive data collection, and they're really interesting, and they're really there's a lot of promise to them. And I think there's a special promise for, as I think the person in the question said, early detection. One thing, Lisa and I have talked a lot about, and I'm particularly interested in, is how do you tease apart the signal you get, though? So, like, the example I always use with her is, someone, you get data from their smartphone or their watch that they're not moving, they're sitting on the couch, they're not doing stuff they used to do. Well, I mean, that could be cognitive impairment, that could be apathy, that could be depression, that could be Parkinson's disease. That really, I think the key with those new technologies is going to be meshing kind of our clinical sense and experience with these novel measures.
Other questions? Well,
I hope this wasn't, I'm sorry, I kind of didn't go over the basics of some of these disorders, but kind
I
of got right
see.
into the.
Tracy, here, you have your hand up.
Yeah, thank you. This is such an interesting talk. And just when you mentioned the availability of these biomarkers, which I've heard about, I don't know much about this field, I should say, but and that some people are fine. Is anybody doing any longitudinal studies of such people who do not have any of the cognitive symptoms, but they have the biomarkers? It'd be interesting to see.
Yeah, and the
do
data
not
is starting to
develop
come
it.
in, and it kind of shows what you might expect, which is if you are positive on the biomarkers, your chance of developing dementia or cognitive impairment or neuropsychiatric symptoms is much greater. But that doesn't mean everyone. So, and I think we're still trying to learn about these people who have the changes, like the biomarkers, and the biomarkers are pretty good or quite good. So if you have positive biomarkers, it does mean you have amyloid and tau, but not all of those people are demented. And so there's a lot of interest in what are the protective factors, what are how does someone have significant pathology but not get a cognitive impairment from it. The other thing that complicates this whole story is that some Alzheimer changes occur with aging. So, when you look at the brain of 90-year-olds, it is not the norm that they have absolutely no Alzheimer changes. The norm is that there are some, and even in people who don't make the cutoffs or are not demented, it appears to be linked to aging, both normal and pathologic aging. So that has to kind of be taken into account as well.
Interesting.
But it's really interesting, and it's part of the reason we don't just go out and do testing on, biomarker testing on people, is that we don't have treatments, number one, and number two, we don't really know what to tell someone. I mean, if someone comes back and they're cognitively normal and they have positive biomarkers, we can tell them that their risk is considerably higher, but you can't say, oh, yes, definitely, you will have clinical Alzheimer's disease in 2 years. We just don't know enough.
What about using these large data sets, like, for example, the Million Veteran Program or All of Us, and then identifying people who have mutations that are suggestive of a neurodegenerative disorder, and looking, correlating them with the phenotypes?
So interesting question. And that kind of was like the first study I did. Some of the issues are vast majority of dementing disorders are sporadic. So in FTD, it's 75%. In Alzheimer's disease, it's 99%. So genetic dementia, the exception to that's Huntington's disease, where it's 100% genetic. But so the vast majority of people with dementia, we don't have a single genetic cause of it. Obviously, the genetics of Alzheimer's is complex, and there's risk factors, et cetera. The other thing that your question brings up, though, is kind of ethical issues too, which is, we really would like to, and this is what we did in that FTD study, really phenotype people very, very well. But there's issues of kind of going out to people and just kind of getting genetic information on them from other sources and then testing it, identifying people. We generally, don't do that because we work only with families. And this research is interesting and challenging, but rewarding in the sense that also, even when you're working with these families, I mean, again, ideally, like that first study I showed you, we'd have everyone blinded, no one would know their status. I mean, again, ethically, you can't do that. You need to, people, need to be able to make their own decisions. And so it has to work around the people. But it is the genetics, one of the reasons I work a lot with these populations is I think I find it rewarding, but also I think it does allow you to explore some scientific questions you otherwise couldn't.
Well, very good. Well, thank you so much. This is very interesting.
All right, fun. Thank you for having me.
Educational for all of us. And as noted, our next seminar will be October 9th, and Rich Fryman and Maren Manuel from the University of Rhode Island and the MCB department at Brown will be talking about their research, which was funded through grant resubmission awards. So thanks very much, everybody. Thank you, Ted.
Okay, thank you. Have a good day.
Okay.
Bye-bye.